Rheumatology and Immunology Culture and Research Institute. His constant stint with research places him on the advisory and editorial board of multiple journals. And in addition to that, he has a multitude of papers in international as well as national journals to his name. Dr. Chandrashekara will speak on managing patients with autoimmune disease and those on immunomodulators at primary care, I think, which is quite not very easy. Dr. Chandrashekara, please.
Two speakers, followed by Dr. Renuka, that most of these autoimmune disease are inflammatory mediated disease or immune mediated disease, whatever we consider under the huge group of rheumatology diseases or diseases of rheumatology or immunology processes, are a little complex disease per se. For two simple reasons. One is, as we have understood and appreciated over a period of time, within a few exception of metabolic diseases, in most of the diseases, immune system plays a crucial role, both in the development of the disease, in the maintenance or clearing the disease, and healing the disease process in a long run. But in these group of diseases, as you are been made clear time and again, that the immune system is not functioning to its best. There is a problem in immune system which otherwise is a guard of most of the diseases from which we are otherwise to be protected. So that being the case, they are not the same patients as they are. In a sense, it's to give a simple example for our understanding, a patient with an infection and diabetes and a patient with an infection without a diabetes need a little different consideration. You cannot handle both of them in the same manner. Similarly, in a patient with a rheumatic diseases, whether he is on or not on the treatment, he need to be treated or managed or thought of in a little separate process, even if it happens to be a regular disease process. Even if it happens to be hypertension, you need to think little differently. Even if he happens to have a diabetes, you need to consider there is an existing problem along with another problem. So that becomes more crucial for us to treat it when it comes to the primary level. So you in a primary care, with the quantum of burden of disease, because the disease, as we put it, it's almost staggering to around 5 to 8% of the population at the prevalence rate. This is happening mainly because, one, the incidence is increasing because of the aging population. Number two, the patients with this disease are also having their increased life expectancy. What happens to be an SLE whose fate would have been said that 95% of the time in the down 5 years would have been dead in 1980s and 70s, he can survive 15 to 20 years. He adds to the number of population who are having a lupus as a disease. Rheumatoid, whose life expectancy is shortened, probably might have another 2 or 3 years because of the disease modifying anti-rheumatic drug introduced early. We still have to have a statistics on that. Probably we expect it to happen. So in essence, vasculitis and other autoimmune diseases, we do expect these patients to live longer than what it happened to be otherwise. This has added to the number of population or a number of patients with a population being in the community who need to be cared. It's always impossible for a tertiary care to be imparted for them for each and every issues. A infection, you cannot reach an rheumatologist or an immunologist or a specialist whom he is under care. Primary care and the peripheral care need to be continued in these patients. In addition to that, they do have a lot of drugs, what we so far labeled as disease modifying anti-rheumatic drugs, immune modulators, immune suppressors, which alters the immunological responses. These make them susceptible to varieties of diseases. So in addition, it's been made clear that these group of patients have higher consumption of medical services compared to other group of patients or other group of individuals who don't have any pre-existing disease. See, the most biggest problem that what we are worried is the immune suppression and the infection. See, the infection is also not an universal problem in all the patients. For instance, if it is a plain hydroxychloroquine, the infection may not be a major problem what we are worried with. It's an immune modulator without much compromising on the competency of the host against the infection. Similarly, methotrexate in a patients of rheumatoid arthritis. There was a huge confusion which was prevailing earlier. Methotrexate is a cytotoxic drug. It is supposed to bring down the immune responses. There could be an immunosuppression. There are varieties of studies which contradicts that. Patients who are on methotrexate with a good control of the disease, the incidence of infection significantly comes down. In a sense, it's not an universal rule that any patient who is on a disease modifying anti-rheumatic drug or on a drug for an autoimmune disease is invariably immunocompromised. So that point should be clear. In a sense, don't see every patient on a disease modifying anti-rheumatic drug as immunocompromised, but at the same time keep eye open that patient could be immunocompromised because of the disease per se. If you look into the SLE, systemic lupus erythematosus, when SLE is active, the patient is more prone for infection like candidiasis, more prone for infection like tuberculosis, and more prone for infections of other variants of especially opportunistic fungal infections. Basically because in lupus, when it is active, the patients are immunocompromised because of a phenomena what it is otherwise called as immune diversion, or also because of the patient may have antibodies against lymphocyte which makes the lymphocyte functioning abnormal. So that may make a lupus patient per se without any immunosuppression being given prone to an opportunistic infections. But again, the drug of choice also dictates. For instance, azathioprine may have a higher infection incidence compared to mycophenolate meftil. Cyclophosphamide may have a higher incidence of infection compared to mycophenolate because the quantum of immunosuppression varies. So because these are all the factors which decides the way the patient is going to present clinically. When the patient is more immunosuppressed, the presentation are subtle. Patient may just complain of excess of fatigue, vague symptoms, complain of vague discomforts, and may come back to you saying that from last few days I am not feeling good, I am not feeling well. If you check, his pulse rates are little higher than what it was otherwise normal, blood pressure is not very consistently okay, and you feel that he is not all that alright. You can just feel that he is not all that alright without really able to attribute some time. It could be an harboring infection. Fever may be so subtle, it may be just 99 or 99.2 towards the evening, which most of the time we take it as normal, may not be the case when it comes to a patient who is immunocompromised because of various of drugs. Sometimes even the symptoms, reflex symptoms like cough and other features like abdominal pain or discomfort may not be as overt or as obvious as you can see in any other patients. Patient may not have a cough as you could expect, and if you take a chest x-ray, it shows huge shadows in the chest films. So in a sense, patient can be asymptomatic because of immune suppression drugs, or patient may be because of steroids or any other drugs that has been used. In addition to that, the infective organism may not be the routine infective organism that you see. Candidiasis is very common. Streptococcus viridans, which is otherwise not a pathogenic organism, can cause it. Other opportunistic infections could be an aggressive infection which you can see in these group of patients. You need to keep your mind open when you are trying to work with these patients, especially when they come down with a subtle symptom looking like an infection. So the spectrum of infection increases, the incidence increases, severity becomes worse, the progression could be more rapid and possible. Even the chronic infections could become flared up. A cytomegalovirus, which is otherwise a subdued infection, toxoplasma, which is otherwise a subdued infection, tuberculosis, which is of a latent variant, can become flared up, especially when you use biologicals. So you need to keep mind open when the patient is probably suspected to be immunocompromised host. See, there are varieties of factors which matters, as I was trying to tell you. The drug that is chosen, the dosage that is chosen, the quantity of drug that is being used, and the duration of the disease drug that has been used. This is just to give an example of a study where they have done is the mean dose of prednisolone with the duration of the prednisolone that is used. You can see that the incidence of infection over a period of time increases. If the steroid is given for a longer time, steroid is given on a higher dose for a longer time, more likely these are the group of patients who are likely to get infection rather than when you give it for a short course. If it given for a 2 or 3 months, you may not expect them to develop much of the opportunistic infection. Even if you give a high bolus, taper it down the lane in a month or month and a half, the quantum of infection you expect if the same dose is delivered slowly over a period of a prolonged time. So in a nutshell, when you are trying to handle a patient who is on these drugs, when they are on these group of drugs, you need to keep these factors under consideration when you are trying to interpret a symptom with which the patient is presenting. So the most important message is the manifestation could be occult. The extent of the disease at the time of diagnosis may not be estimatable. What you are thinking is, it's okay today, the patient is fine, let me send him to a higher center tomorrow. It may so happen in the middle of the night, you may get a call from the patient, patient's blood pressure is sinking and patient is not responding. It may so happen in immune compromised patients. So another important issue, that is infection may not be as responsive as it can happen in a normal host. The reason is, as all of us know, that when we use an antibiotic, 50% is contributed by the antibiotic, another 50% is contributed by the host in clearance of the microorganisms. In an immunocompromised host, depending on the extent of immunocompromise, his contribution of 50% may range from 50% to 0%. In a sense, the amount of antibiotic you may be pumping in, the choice of antibiotic that you are going to choose basically should depend upon what it can happen. So you may be giving him and pumping in with a higher antibiotics, patient may not be doing any good response, basically because patient's response may not be adequate in the elimination of the drugs. So that's why the most crucial becomes is the rapidity in which you make a specific diagnosis, how quick you are able to identify the organism that is causing the infection, and also to initiate a specific therapy. I recall in the recent IRA meeting we had a CPC wherein it was a SLE patient, the death was finally could be concluded was because of invasive aspergillosis. Basically when we were trying to work out or figure it out, the aspergillosis was missed because the aggression at which it moved was much faster than expectations. In a sense, even the best higher centers, this happens. So that being the case, you need to be a little more cautious when these patients walks in with a symptom where you are little suspicious of possibility of infection. You need to be little more alert than regular patients. You need to be more careful to make a quicker decision to take whether we should go aggressive or whether we can wait for some time. So another problem is the question that remains is whether it is a side effect associated with the current drug or is it a problem which is totally independent or totally a different problems together. But what is most crucial, as I put it, it is best to prevent a possibility of infections. Most of these guidance are given and also should be instructed repeatedly in the primary care to take things into a better shape. So to prevent the infections, one is go for immunization, explain him about the appropriate infection control and look for how to handle him or how to help him out. See, because there are simple suggestions like the question they ask is, can I eat out? Can I eat outside? See, the usual answer is that if he use a boiled item more often than an unboiled item, less likely he is going to get an infection. More often we forget that along with dosa, a chutney comes. The chutney is absolute an unboiled item. And we really do not know what else he has used while making the chutneys. And another important thing I still saw in one of the stall, I think recently, that distillery water is used for the preparing the pani. But when pani puris, the pani becomes one of the biggest culprit. He has put a separate notice saying that distillery water is used for making pani puri. So in a sense, he is wise enough to say that I have taken care of contamination of pani puri. But still, I can tell you, while making pani puri, I think if you really check with them, there are a lot of other processes which takes place. Anywhere else, when the boiling is not a process, possibility of infection becomes more. So you should warn the patients, caution about the patients. This looks so simple, but usually missed by even the best cooks who are otherwise a best cook and a patient, that they forget that there is a possibility of infection. That's where we call as engineering the control. It is a very simple thing to a very complex thing, how best one can avoid an infection control at home, outside and at periphery. And one need to keep on a selected screening for latent infection. So as we are insisting, before starting a biologicals, a latent infection search for tuberculosis should be done, because studies have clearly indicated anti-TNF drug is one of the responsible factor for flaring a latent tuberculosis. So you need to look for it. You need to examine thoroughly, which most of us do when the patient walks in, is for any other source of infection. Throat is clear. Is there a candidiasis? Is any other infection in the chest, any other site, urinary tract? So we just try to look for any such infections much before we start the immunosuppressions, or if a patient is already on immunosuppression, keep looking for a possibility of these kind of infections. If you figure it out, try prophylaxis, which you could otherwise say that it's okay, you just hold on for some time, it clears up. In a normal host, if you find a small throat, a small viral infection or a bacterial infection somewhere in the skin, you are at a liberty to say, wait for a couple of days, it may disappear, you need not bother about a furuncle. We may not prescribe an antibiotic if there is a small furuncle in a normal host, but when it comes to an immunocompromised individual, you need to be a little more careful, keep a watch whether furuncle is going to become an abscess. That furuncle itself could be the point from where the whole infection may become into a sepsis. So you need to little more careful in preventing further spread of infection much more before is preventing the infection per se. So as you know, these are all the process which you look into when you are going for immunization. Most important is usually we need to use inactivated vaccines. One of the questions that they may come back to you asking is, can I use a live viral vaccine? Usually when the patient is significantly immunocompromised or used with a higher immunosuppressants, avoid using live virus vaccines. If there is a need, check out with the specialist should this live virus vaccine can be administered or not. No doubt immunization is a valuable accompaniment in handling these group of patients, but one need to take care using more of non-live vaccines rather than live vaccines. When a patient walks in with a fever, there may not be any symptom or any localizing symptom, as I said. A thorough, careful clinical examination is required. It may be a teeth, it may be a periodontum. Patient may not have a symptom. He may not complain of teeth ache or teeth pain, basically because there may not be an adequate inflammatory reaction. So for a pain to generate, it's the inflammatory reaction which is required, which is prevented or stopped in an immune compromised host. He may not give so much of complaint of pain at the site of infection. He may not have so much of discomfort even if there is a pharynx is congested or you can find the candidiasis. He may just say that I find little difficulty to eat, but he may not have that complaint. So you have to thoroughly check pharynx, look at chest for any infections. Do not hesitate to over investigate sometime these immunocompromised hosts. You may find surprising, you take a chest x-ray, you may find on the apex a huge cavity or a huge pneumonia sitting up there. Look carefully for perineum. Usually that's one of the sites where we miss. We keep struggling, where is the source of infection and fever. Skin, if necessary. Bone marrow aspiration, of course vascular access, it's only in the renal transplant patients where that's one of the sites where we are worried. Eye, a fundoscopic examination that may tell you that there is a small fungal nodule, and tissues around the nail. These are the usual sites source where you can find an infection without patient giving more complaint on these areas. When you go for a drug of choice, prefer bactericidal. As I said, in bacteriostatic drug, the contribution from the host in clearance of the bacteria is higher than a bactericidal drug. Preferably use bactericidal drug. Most important is you have to keep in mind the drug interactions. Example, if patient is on anticoagulant, cephalosporin should be avoided because it can prolong the APTT and PT-APTT prolongations. And if there are drugs which has nephrotoxicity, if patient is already on cyclosporin, preferably avoid them. So you need to look into those group of drugs. Antitubercular, when patient on methotrexate or leflunomide, you should think twice to add because most of the antitubercular in 4-drug regime are hepatotoxic. Methotrexate could add to an hepatotoxicity. You need to either, if possible, to withdraw this drug or carefully add or increase the monitoring frequency when you are going to add anti-tuberculosis with methotrexate and leflunomide. CYP inhibitor, which are most of the antifungals are there, and quite a few of these DMRs or these CYP inhibitors, they could have a drug interaction, especially when you are using antifungal with the new generation drugs which are likely to come into the market in another 1 year. Most of those inhibitors or CYP inhibitors, we need to be careful when we are trying to introduce an antifungal. See, another problems that we may face other than infection is the patient may develop the other problems related to the drug per se. For instance, to give a patient who is on steroids, patient may start developing diabetes. He may come back to you with a simple fatigue, weakness, or other typical characteristic symptom of a diabetes. You need to keep a watch on that. You need to keep monitoring on that. Keep a look on hypertension. Patients may land up with an osteoporotic fracture, where patient may be just brought in saying that from last 2 days he is not walking. Your first reflex should be, is there a fracture at the fracture neck femur, especially the patient is on steroids. So the basic knowledge of these complications can tell us. The other most important thing what we sometimes forget is the patient who is on steroids may report back to you with saying that from last 4 or 5 days I am having excess of vomiting, continue to have a pain abdomen, lot of discomfort, I am not able to eat anything and I am excessively fatigued. Please remember, there could be a simple possibility that he might have discontinued steroid with an advice of some of his friend or another medical practitioner saying that steroid you are taking, you discontinue. So a sudden discontinuation could land him in an Addison crisis. The patient may have a very subtle Addison crisis with which patient may walk in to say that repeated vomiting, abdominal cramps and vague discomforts could be simple Addison crisis. Giving him back another 15 milligram of prednisolone will set him right and you can send him back. So you need to look into these kind of situations based on what drug he is taking. Another biggest challenge when we are trying to follow up these patients at periphery or even at our in a higher center is mimickers of infections. Whether it's an infection, whether it's a disease is always the biggest challenge which comes to us. If person has a pneumonitis with an SLE, the question remains is whether it is an infective pneumonitis or whether it's a pneumonitis to lupus, or whether it is because of a drug per se, because cyclophosphamide is one of the drugs which we use in interstitial lung disease, itself can produce pneumonitis, itself can produce a lung fibrosis. So you always have a biggest challenger that is it a simple plain mimicker of the drug per se rather than a infection or the disease. And other problem is like hepatitis. Enzyme level of SGOT-PT are increased in the follow-up as been previously told when you are monitoring. Now we really do not know whether it's because of methotrexate or whether it's because of a hepatotropic drug, infections. There are many viral infections other than Hep B, Hep C, A and E, lot other hepatotropic virus which can produce an altered liver enzymes. So you need to little bit careful when you are trying to exert your skill in decision making with this background, could it be a virus infection rather than the drug itself. Most biggest challenge that comes to any person who is trying to take care of them is, can I discontinue immunosuppressant for a short while? If a patient walks in with an infection, should I stop the drug that he is taking? A rheumatoid arthritis patient comes with a throat infection, rheumatoid arthritis patient comes with some fever. When you are trying to prescribe other medication for fever, should we discontinue these drugs? See, the question that remains is, you need to be exercising a most important clinical decision making, whether the primary problem, how much it is active and what is the drug in question. As I said, if it happens to be steroid, it is best not to discontinue steroid at any point of time. If the patient is on a steroid say around 20 milligram or 30 milligram, as all of you know that during an infection crisis, the body's demand for steroid increases. Normally, the body increases the secretion of steroids to counter-regulate various infection-reacted responses which happens from immune system. So that when the demand increases, it would be wrong on our part to pull off the steroids. So you need to maintain some amount of steroid dose. If there is a drug like azathioprine, counts are low, check the counts. If counts are low, then you are very sure probably the reason for infection could be a drop in count. You can always pull off the azathioprine. At the same time, if the disease is very active, you need to introduce some alternative to the controlling the disease process. So also an additional whatever the problem that has set in, and then try to manage it. So the basic question is, to withdraw an immunosuppressant, you need to be very clear how far the disease is under control. By withdrawing the drug, what is the likely possibility that you are likely to inflict on the patient. So you need a clear-cut judgment with reference to these drugs while trying to withdraw. See, if it is methotrexate is on, if you are going to introduce another drug when there is an infection, counts are normal, in a rheumatoid arthritis patient there is no need to withdraw the methotrexate. You can add another antibiotic which you are trying to prescribe for him. Suppose you are forced to prescribe a drug which is otherwise hepatotoxic, you can withdraw for a week or 2 weeks of those course of period, because in rheumatoid skipping 2 doses of methotrexate is not going to make a major impact. But when it comes to SLE, skipping steroid for a week or 2 weeks could be deleterious. You need to take a call. In that situations, you need to be little less or slow in pulling off these drugs. So the most important is, and that's the theme of this particular entire of this today's CME, that's why you have a balance in front of the whole of the brochure is how to balance and help and resolve the problem of the patients. Because on one end you have a high toxic drug which is required to maintain and manage rheumatological disease, with an exceptions of few. At the same time, the disease per se could be destructive or damaging. So a good balance need to be taken care. The same idea and inference should be applied when these patients walks into any of the primary care for any problem other than the basic problem for which he is being treated. So the decision is crucial. Over a period of time, with a good amount of knowledge and information, we should be able to take a right decision and a right step in managing these group of patients. Thank you very much for patience.
If anybody has any questions, they can please start asking now.
Regarding immunization, before we start the immunomodulation, what is the ideal time to use those immunization schedules?
You mean the immunization schedules?
Before we are thinking of an immunosuppression and immunomodulation, what is the ideal time to?
No, actually the best is, see, now the decision of vaccinating or not vaccinating basically depends on at what stage the patient has walked in. If you have a time frame of 3 weeks or 4 weeks before starting immunosuppression, one can plan for giving them vaccination and go ahead. This can happen only in a situation of renal transplant where the whole process is planned. Immunosuppression can be planned. When it comes to handling the rheumatic diseases, it's not under our control, because patient walks in with a lupus or a vasculitis, you need to immediately institute the drugs or the treatment. So the best we try is the prophylactic and engineering the infection as less as possible. Try some of the other inactivated vaccines where it is possible, but they are best given when the minimum immunosuppressions are there. So when you have a very high end immunosuppression, no vaccination will help anyway, so it's not worthwhile to give at that point.
So happens some of the vaccines, the killed vaccine is not available. It's always many of them are only live attenuated viruses, where the killed vaccine is, there is no choice, no option.
What we do is the risk of giving the vaccine is much higher than not giving it. So that being the case, we take a choice on not giving it. So the live vaccines are almost not indicated in a patients who are immunosuppressed, because even those attenuated virus can cause a pathogenic process.
Sir, you made a mention about the bacteriostatic and bactericidal antibiotics in handling the infections in an immunocompromised patient. My point is, does it need in addition to bactericidal, does it need a very aggressive treatment of these infections, like for example tuberculosis with the multiple 4-drug tuberculosis management, or any of the antibiotics, a higher therapeutically permissible full dose of antibiotic to be given to handle the infection?
Actually, see, I somehow don't agree or believe with those words called higher antibiotics. It's actually somehow it's very vaguely used in the medical terms. There is nothing called an higher antibiotic or a lower antibiotics. The end game is the bacteria which is in question is sensitive or not sensitive. So when you get a chart of the sensitivity, they give the diameter of inhibition and the quantum of inhibition by the various antibiotics that was given. So there the choice comes is the bactericidal which has a highest diameter of inhibition should be taken. So the basically that indicates that that particular bacteria in question is highly responsive to that particular antibiotic. So see, it is not that the new generation imipenem is a higher antibiotic compared to Bacterium DS. Let me tell you, the Bacterium DS has a much higher bactericidal property than the imipenem group of drugs. Even the coverage wise, the cotrimoxazole combination has a much better wider coverage than the imipenem. So the only thing is when the bacteria in question is resistant to this trimethoprim and cotrimoxazole combination, have a higher wider range of inhibition to the imipenem. Imipenem is a better drug than this. So it's basically the drug sensitivity of the bacteria which decides which is the best to take up. So that's why whenever you suspect it in immunocompromised host, best is to send a culture, choose what is best available in the epidemic information wise, the most easily best treated, most well used or less used drug, and then choose out the other next group to work out it. Actually, that's the best way to work on that areas.
Sir, I feel in a immunocompromised, the greatest challenge is to identify the infection, because the major infections also can become totally asymptomatic or very, very minimum symptoms, and the biggest challenge is to identify. For example, infections in the lungs like pneumonias, like tuberculosis or fungus infections or urine infections, any of the pelvic infections, UTI is very difficult to pick up because there may not be any symptoms at all.
Yeah,
so the greatest challenge is in identifying these things.
Actually, see, that's one of the reason I mentioned one word called it is sometimes better to over investigate rather than under investigate a patient of immunocompromised. If you are worried about the possibility of infection, send for urine culture, blood culture, sputum culture, and if there is any other source of abscess, to send for the culture. See, under normal circumstance, what is the best practice? What we normally do is, if the patient is normal, non-immunocompromised, if he complains of urine burning or sensation, urine shows pus cell, that's a point when you try to send a urine for a urine culture sensitivity. Or if a patient has a cough, brings out the sputum, that's a point when you try to send it. But this law is to be little violated when it comes back to an immune compromised host, because you really do not know where is the organism, where it is. And to tell you that actually the chances of getting a positive culture is much higher in an immune compromised host than in a non-immune compromised host, because he allows bacteria to grow in a best way and a best number. So the microbiologist will also be very happy to culture it because they get a more of a positive culture with these set of patients. Only thing is, never send it after a push of antibiotic. So once you push an antibiotic, the whole thing goes wrong. So the best is, if you suspect infection, send for the culture in whatever the possible sources of area you look for, and simultaneously start an antibiotic. Then you will be wise enough to start a right antibiotic in next 48 hours.
Sir, is there a high percentage of antibiotic failure in these patients?
Yes.
Antibiotic failure and no
Yes,
response,
yes,
and
yes.
the
Now,
infection takes an upper hand.
The problem in the immune compromised host versus the non-immune compromised host, especially most of this work is from the neutropenic patients, because we have not much work with reference to the other immune compromised host, is the mixed infection. The biggest challenge and the biggest problem is a mixed infection. You may have streptovirus, E. coli, and one more pathogenic organism being a mixed infection. See, what really happens is, it's our practice when we are trying to culture it, we figure out which is the highest grown and we think that is the organism that is responsible. A choice of antibiotic goes to that. So that's why in some of the, there is a lot of revision that is going on in choosing the antibiotic in neutropenic patients. They say if there are three bacteria are isolated, give for all the three an antibiotic which covers all the isolated bacteria, so that failure chances are less. See, what may happen in a normal host? Suppose a normal host by mistake gets this mixed infection, mixed sepsis. Once you reduce the bacterial load, immune system can take over the whole disease process. But in these patients, there is absolutely no support from the host. So you need to handle extensively from your medications and drugs.
Excuse me, sir. In patients of lupus who present with fever and respiratory complaints, the main confusion is between lupus pneumonitis or an active infection. Generally, what we are doing is we are giving high dose steroids along with an
Antibiotic.
high dose steroid with an antibiotic. Maybe CRP there might be some benefit of diagnosing infection. What is the protocol? Do you go ahead based on clinical judgment only, or do you plan for BAL or other procedures to rule out infection? Or
Actually, the first immediate response is you cover both, but simultaneously you should start working to get a reasonable diagnosis. So you need to, one is to get an X-ray chest, look for C3, CRP and C4. CRP is 6 times more than the normal basal cutoff. Probably it clearly suggests that yes, there is an infection. But once again, in pneumonitis of an SLE also it can rise, but normally it doesn't rise more than 2 to 3 times. It's very unusual to rise such a higher value. Simultaneously look for culture and any other markers of infections which you can get. So if they are all negative, most likely what you are handling is pneumonitis. You can withdraw the antibiotic that you have prescribed, go ahead with steroids. So the other way, if you find it, so is go ahead with antibiotic, pull off the steroids. Anyway, increasing a short-term steroids, as I said, is not going to really harm a patient. You are supplementing a steroid demand which was otherwise asked by the organism, by the body to cope up with that infection stress.
Sir, in connection with cardiovascular morbidities, now there has been a paradigm shift from looking at cholesterols to looking at homocysteine levels. And homocysteine antagonizing factor is our folic acid. 5 milligrams of folic acid as a prophylactic dose it is given. So in the scenario where a person has either RA or SLE where methotrexate is given as an antifolate, so how do we kind of assess the situation, or how do we?
No, as far as at the current scenario, we don't have any guidelines with reference to this, because there is nothing to say that you need to do a baseline homocysteine before introducing methotrexate is not advised nor practiced anywhere. As you said, in a patient who has a homocysteinemia, the introduction of methotrexate can cause increase in homocysteine levels. And we did have a patient in what we have seen, a patient of rheumatoid, methotrexate introduced, within 3 weeks he developed a CVA, admitted and referred back for rheumatoid arthritis back to us. We did find that, but it's not a normal scenario which we see. Say out of maybe around 20-25,000 patients which we have seen through, probably this is one of the patients which I have seen who has come back with that. So because for one patient, subjecting the rest of the patient for homocysteine levels is not advisable or not advised. Now regarding the changeover in whatever the way the cardiac profile is done, I am not the right person to answer that. Probably cardiologists who are regularly following should answer it. But as far as I know, homocysteine is taken as a part and parcel of it, but they still believe that the lipid profile, the HSCRP, the other things, they are all taken into consideration while staging the risk factors. For a rheumatologist perspective, most of the rheumatic diseases are a high risk diseases which produce a high risk cardiovascular mortality, including rheumatoid arthritis. A good control of rheumatoid arthritis with methotrexate is said to reduce the risk of cardiovascular mortality in rheumatoid arthritis patients. So rather than it increasing homocysteine and causing a problem, we have seen there are enough literature which has gathered around to say that if you introduce methotrexate early in rheumatoid arthritis, you can postpone a cardiovascular event in rheumatoid arthritis patients significantly. We give normally around 1 milligram to 5 milligram in different circumstances, and sometimes we have even gone up to 30 milligram per week of methotrexate. Basically, it depends on the symptoms and signs with which the patient comes. If the patient complains of recurrent oral ulcers, we increase the folic acid dose. If the patient comes back with a hair fall or any other such symptoms, we increase the folic acid dose. Otherwise, normal practice is whatever the dose, we land up in giving a backup of 5 milligram of folic acid weekly.
Yeah, thank you, Dr. Chandrashekara, for an extensive and a very comprehensive